Hypertrophic cardiomyopathy is a disease of the myocardium defined by left ventricular hypertrophy without secondary causes such as hypertension or valvular disease. It is one of the leading causes of sudden cardiac death in young individuals. Prevalence is approximately 1 in 500 individuals globally. It can present with heart failure, syncope, or remain completely asymptomatic until sudden cardiac events occur. Around 50% of cases are due to sarcomere gene mutations, most commonly H7 and BPC3. Penetrance is incomplete and age-dependent, leading to wide variability even within families. Pathophysiology includes myocyte disarray, hypertrophy, and interstitial fibrosis. There is increased calcium sensitivity and abnormal energy utilization at the cellular level. Left ventricular outflow tract obstruction occurs in up to 30% at rest and can increase with exercise. This produces systolic murmurs and may worsen mitral regurgitation. Microvascular ischemia contributes to angina and replacement fibrosis over time. This increases the risk of ventricular arrhythmias and sudden cardiac death. Clinical presentation ranges from asymptomatic individuals to exertional dyspnea, angina, palpitations, and syncope. Symptoms often worsen with exertion or dehydration. Diagnosis relies on echocardiography showing asymmetric septal hypertrophy and possible obstruction. Cardiac MRI helps detect fibrosis and scar burden. Electrocardiography is often abnormal but not sensitive. Genetic testing confirms mutations and is important for family screening. Athlete's heart must be differentiated from HCM because physiological hypertrophy is reversible and associated with normal diastolic function and high exercise capacity. First-line treatment includes beta blockers and verapamil to reduce heart rate and improve diastolic filling. Disopyramide is added for persistent obstruction and symptoms. Diuretics may be used cautiously for congestion, but excessive preload reduction can worsen obstruction. Careful volume management is essential. For refractory cases, surgical septal myectomy is highly effective in relieving obstruction. Alcohol septal ablation offers a less invasive alternative. Implantable cardioverter defibrillators are used for sudden death prevention in high-risk patients. Risk stratification is based on prior arrest, syncope, wall thickness, and family history. Atrial fibrillation is common in hypertrophic cardiomyopathy and requires anticoagulation and rhythm or rate control. Certain drugs like digoxin are avoided due to increased obstruction risk. The European Society of Cardiology Risk Calculator estimates 5-year sudden death risk. Patients above 6% are strong candidates for defibrillator implantation. Overall prognosis is favorable with modern therapy, with mortality under 1% per year. However, a small subset progresses to end-stage heart failure with systolic dysfunction. Long-term follow-up with imaging and family screening is essential due to genetic transmission and risk of arrhythmia. Early identification of relatives improves outcomes significantly.